Hello, friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hey friends, welcome to part 2 of the trauma primary survey. In this episode, we're talking about C, D, and E. So if you recall from the last episode, quick recap. We talked about the primary survey for trauma, which includes airway, breathing, circulation, disability, and exposure. So in this episode, we are going to start with C and talk about circulation, disability, and exposure. So jumping right in for circulation, another thing to think about when you're thinking about circulation as any cause of bleeding. The cause of shock and trauma until otherwise proven is bleeding. If somebody looks like they're in neurogenic shock, assume that they're bleeding. These are the rules of trauma. So everyone is bleeding until proven otherwise. Because of this, everybody should have intravenous access ASAP. Everyone should get intravenous access ASAP. And so for this, you want to have 2 large bore IVs. This is kind of like in the protocol. So large bore being like 18 or greater. So that would be 18, 16, 14. The gauge of the needle is larger with a smaller number. That's just the way that works. So 2 large bore IVs. You can do what's called an interosseous line or an IO if necessary. And so an interosseous line basically goes typically either in the humerus or the tibia. I've seen it most commonly in the trauma bay in the humerus, so in the head of the humerus. Basically what you do with an interosseous line or an IO is you drill into the marrow of the bone, and from here you can administer fluid or products through this route. One thing to note about this that I didn't really know when I was starting out is that interosseous lines are extremely painful to infuse through. So if you don't have to do an interosseous line, obviously don't drill into bones that you don't need to. I'm looking at you, my ortho friends. You don't need to drill into these bones if not necessary. And if you do need to and you have time, you can give lidocaine first to make it a little less painful for the infusion. But just know that if you're going to start pushing fluids through and your patients are screaming, it's probably because of that. So like we said, shock is hemorrhagic until proven otherwise in this setting. And when we think about hemorrhagic shock, especially taking a glance at a patient, some ways that we can assess hemorrhagic shock, if there's no obvious source of blood loss, obviously if you see a bunch of bleeding, that's what you're going to assume is happening. But things that can kind of clue us in that this is happening if there's no obvious external source would be altered mental status. So if the level of consciousness of the patient is altered at all, if they're aggressive, if they're super confused, if they're drowsy, that can kind of clue us in that they are not perfusing the way that they should. And another thing is like the color of their skin. So if typically people are going to look warm and perfused and pink, and depending on the color of your skin at baseline, it's easier or more difficult to assess this. But when people start to get ashen, gray, pale, you can kind of, or cold when you're touching their skin, obviously, that can kind of give you a clue that they're not perfusing, their skin is not getting perfused. And then pulses when people are in hemorrhagic shock can be rapid and thready. If people are super hypovolemic, you can even lose pulses. It can be hard to feel a radial pulse, and you might have to do femoral instead. When thinking about blood loss, there's a couple of buckets to think about in a trauma situation. There's a saying or a mnemonic called 4 in the floor. So starting with the floor, this is exactly what it sounds like. The floor is bleeding externally. And so this would be somewhere that you can see they're bleeding and it's touching the floor or something else. But external bleeding would be the floor category. And then the other 4 places that you can lose a ton of blood are going to be in the thorax, so in your chest, intraperitoneal, retroperitoneal, and then long bones. Starting sort of from the top, each hemithorax, so each side of your lung cavities can hold about 1 to 2 liters of blood per hemithorax. So you can lose like 2 to 4 liters in your chest. And so this goes back to what we were talking about with breathing. We want to make sure that there's not a whole bunch of blood building up in the chest. And if so, we need to do something about that. And so like chest tubes are helpful for evacuating that so the lungs can expand. But if that continues to drain a super large large volume, like say for instance, there might be a cutoff that you might need to do a thoracotomy, or you might need to operate if there's large volume hemothorax, which we can talk about in a different episode. That is going to be concerning. But just to start out, each hemithorax can hold about 1 to 2 liters of blood. So that can become very concerning and can make somebody hypotensive and can mean that they need blood if you see a hemothorax on chest x-ray. The peritoneum, so your intra-abdominal cavity, can hold your entire circulating blood volume. So bleeding in your peritoneum is extremely dangerous, and you can bleed from all sorts of places, commonly in blunt trauma, so car accidents, anything not penetrating like a gunshot wound or a stab wound or something like that. You can sort of injure anything in your abdomen, but solid organs tend to bleed quite a bit, so the spleen and the liver are pretty commonly injured in blunt trauma, and they can bleed. There's all sorts of grading systems for how severe the trauma is to your liver, kidney, and spleen. Those are kind of your solid organs. You can consider pancreas in that bucket as well if you want. And then you can also have hollow viscous injuries. So this is going to be injuries to things like the stomach, the colon, any sort of bowel injury is a hollow viscous injury. So if it can contain air at baseline, it's hollow viscous, or if it holds something to do with your digestive system, hollow viscous. And then solid organs are going to be liver, kidney, spleen, plus or minus pancreas, depending on how you like to think about it. You can hold a ton of blood in your retroperitoneum, about 4 liters. And this is important because one thing that can cause retroperitoneal bleeding, so we talked about kidneys already, so kidneys are technically retroperitoneal. And so if you have like a renal artery, renal vein injury, or big renal laceration, that can cause a ton of bleeding. But what you might not think about when you're starting out is that pelvic fractures can lead to tons and tons and tons of retroperitoneal bleeding. In fact, so much so that we have an intervention that we can do in the trauma bay for pelvic fractures if somebody has what's called an open book fracture. There will be a picture of this on the Instagram, but basically an open book fracture is where the pubic symphysis, so you have the symphysi, I reckon, so you have the two that meet in the middle and there's that little disc in between them, those sort of pop open, and that's going to be your open book fracture. And so when you have something like this, that can cause shearing of retroperitoneal veins, and that's where the bleeding comes from. And so what we want to do in this situation, and you'll find that this is kind of a theme in trauma or a theme in medicine in general, is that we want to return things to the shape that they were previously in to make it better. Okay, so this applies to the pelvis and to broken bones, etc. Like you want to fix them and put them into the shape that they were in before, because that's where they like to be. And so when you have this sort of splaying of the pelvis, what you want to do is wrap it back together. And there are like commercial binders where there's like fancy binders where you can wrap them up and it's a whole device, or you can just use a bed sheet and some towel clamps. And this is kind of a 2-person job because you want it to be really tight. But basically you want your sheet to be centered on the greater trochanters of the femur to sort of pull that pelvis together. And you want to make this as flat as possible because any wrinkles can cause pressure injuries and it's uncomfortable, but also we want this to sort of like hold things together and not bunch up and roll around, especially with an unstable pelvis and concern for lots of bleeding. So the 4th category, so far we've went over the 4 on the floor. So we talked about the floor, the hemithorax or hemithoraces, the peritoneum, the retroperitoneum, and the 4th category or 5th category is the long bones. So for instance, the femur, with a femur fracture, you can hold up to 1 to 2 liters of blood per thigh. So that means up to 4 liters of blood in your thighs if you have bilateral femur fractures. And so again, like we were saying, you want to, in this situation, obviously recognize that the compartments of the leg may be becoming very tense. They may lose distal pulses in this case, but more urgently, I guess, is like if they're having this extreme bleeding into their thighs and you recognize it, or they have an externally rotated leg, or there's shortening or what have you, if there's some sort of malformation of the leg, you can put them in traction in the trauma bay. And I think as a part of the primary survey, you're not going to be casting people, but you can put them in traction pretty quickly. And this is important because, like we mentioned before, putting them back into their anatomical position can help to reduce that bleeding. It can help to reduce nerve injury. It can resolve ischemia. It can give you your distal pulses back. And what we don't want to do is lose more blood, have more damage to tissues. And so putting things back in their anatomical position, as much as you think as a med student it might be exquisitely painful for you to be touching their broken limb, putting it back where it belongs is actually extremely more comfortable than it being in a splayed or broken position. So, and also pain medication is a part of the primary survey typically, and so that's not something you should worry about. So when talking about external bleeding, so just sort of some management details. For an approach to external bleeding, this is something that you're probably familiar with, but first thing you're going to want to do is apply compression. Direct pressure to a bleeding site is ideal. So obviously we're not going to do this on the abdomen. So if there's like a gunshot to the abdomen, you're not going to stick your fingers into the peritoneum because that is not necessarily going to work because there's no way for you to directly push on that vessel. But if it's like in the leg or the arm, even on the neck, you can hold pressure as long as you're not compressing both carotid arteries. First step is direct pressure. And so with direct pressure, we think about pressure the way that we think about it in physics. And so what we want to do is sort of reduce the area that we're pushing down. So placing your palm on something that you want to apply pressure to is going to apply less pressure than applying just a fingertip. So if it's possible for you to push down with a smaller area, that's going to increase the force that you're going to be able to apply to that area. So sort of reduce the area that you're pushing down, push hard, especially if it's arterial, and just hold it there. No peeking. I would hold until somebody tells you to stop holding. And if that's not working, the second thing you can consider is packing the wound. And so again, we're not going to pack the abdomen unless we're in the OR because it's not really going to be helpful from an external perspective, but you can pack the extremities. As far as packing goes, someone will help you with this in the hospital, but if you're pre-hospital, so just out in the field and this happens, packing is going to apply pressure, and you can apply a pressure on top of your packing, but basically you'll take like a Curlex, which is just a roll of gauze, and shove into that until you can't get any more in, and then you can apply direct pressure on top of that. And this is just applying pressure. Some of these packing agents can be hemostatic, so they can be infused with things that promote the clotting cascade. Probably not something you're going to do in the bay, at least at my institution. You can pack, and that is an option. Another thing that you might see on trauma for an approach to external bleeding are tourniquets. And so some rules about tourniquets, not that you probably will be putting a whole lot on your time in trauma, maybe, unless you're pre-hospital or you are transferring to other centers and you need to put one up. Things that you should always do is like note the time that the tourniquet goes up. And so people who are pre-hospital who are trained in tourniquets should be writing the time of the tourniquet on the device. That is important just so you know how long the ischemia time is of the limb, and that's important for like reperfusion injuries and thinking about viability of the limb and how fast you're going to take the tourniquet down, etc. Another thing is you should not have pulses distal to the tourniquet, and so the whole point of the tourniquet is to stop the blood flow to the injury so that there is less bleeding. And so if you feel pulses distal to that, your tourniquet is not tight enough and you should tighten it. If you do find yourself in a position that you need to make your own tourniquet, some things to note is that you should not use a thin piece of cloth or string because it can cut into tissue, which is not the goal. So when you're trying to apply a tourniquet, you might accidentally amputate their leg or cut through a bunch of tissue, and that's just like not ideal. So your tourniquet should be one 0.5 or greater inches in width. So like about a thick belt is kind of a good marker for that. We don't want to use anything skinnier, because if you get it on as tight as you need to, it can start to cut into tissue. And that's just sort of adding insult to injury. The whole point of a tourniquet is to, like I said, occlude bleeding, occlude the vessels proximal to where the bleeding is coming from. And so if you cannot identify where the bleeding is coming from, the old adage is high and tight. And so where this would be like on the leg is going to be in the groin. So that's going to be cutting off the femoral artery, which is supplying the leg. In the arm, you would do high and tight sort of at the shoulder, going to occlude the blood supply to the arm. But if you can identify where the bleeding is coming from, you want to go sort of more proximal to the injury, but not as high as possible, because you are inducing ischemia to all of the tissue that is distal to your tourniquet. And so trying to minimize that while also obtaining hemostasis is really important. So this goes maybe without saying, but I sort of touched on this before. We do not tourniquet the neck or the abdomen, because it's just not going to help. So some approaches to internal bleeding. This is where we start to talk about adjuncts to the primary survey. So thinking about the primary survey in some institutions, at mine, for example, there are some adjuncts that we do during the primary survey, namely a chest x-ray and a pelvic x-ray. So the chest x-ray is done during the primary survey, and this can show hemothorax, pneumothorax, tell us if we need to do chest tubes or needle decompression, and we sort of talked about that in the last episode. But can also show us if we have massive hemothorax, and if we need to do some other intervention quickly. Pelvic x-ray, like we talked about, can show pelvic fracture. We talked about an open book pelvis, and this again shears retroperitoneal veins and can cause massive hemorrhage. So this is something that you do want to deal with as soon as you see it. So if you know what you're looking for and you're out in the field, you can make a binder yourself. You just wrap a sheet or something wide enough around the patient's greater trochanters to sort of push that pelvis back together until you can get someone where they need to go. Another sort of imaging thing that can happen in the bay is called a FAST exam. This stands for Focused Assessment with Sonography for Trauma. This is an ultrasound exam, and there are 4 views. If you do the FAST exam, there's 4 views. If you do the E-FAST exam or the extended FAST, there are 5 views. So the typical 4 views that you'll see are right upper quadrant, left upper quadrant, bladder, and heart. So for the right upper quadrant, you're looking for the interface between the liver and the kidney, which is called Morrison's pouch. This is where blood can pool. In the left upper quadrant, you're looking for the interface between the spleen and the kidney, which is also like splenorenal fascia. You can also look perirenally. Pararenally, you can see bleeding in those areas. For the bladder, you aren't necessarily looking at the bladder, although you can sometimes see disruption of the integrity down there, but you're looking in the pouches in the pelvis, which are like the pouch of Douglas, the rectovesical pouch, the uterovesical pouch. Listen, these are so hard to say. You're looking at the pouches in the pelvis to see if any blood has pooled down there. And then in the heart, when you're looking up, you have a subxiphoid view. So you're looking through the liver at the heart. And in this view, you're looking for pericardial effusion, but you can also see if the patient has cardiac activity. If they don't have cardiac activity, that is a sign that you need to be doing something else probably than an ultrasound, but it's something important to be looking for. And all of those things can basically tell you, is there blood in the abdomen? Is there blood around the heart? Is there something that I need to do? And most of those things have some sort of intervention if necessary, if the patient is hemodynamically unstable. And so that's just something important to know, that what they could be doing with the ultrasound, and sort of know what they're looking for in each view. All right. Thinking about management of some of these things in the trauma bay, we talked about this already, but managing blood in the thorax is typically managed with a chest tube, and we will talk more about chest tubes in their own separate episode, what massive hemothorax is, what management for that is, etc. But what you need to know in this episode is that if there is blood in the thorax that needs to be drained, there will be a chest tube placed. If there's blood in the abdomen, if a patient is hemodynamically unstable, we know there's blood in the abdomen, we know they're bleeding, they typically will go to surgery. If somebody is extremely hemodynamically hemodynamically unstable, there is something called a REBOA, or a resuscitative endovascular balloon occlusion of the aorta, which is basically just like a really large balloon that you can blow up in the aorta to occlude it distally to some point that you choose, so that you're still perfusing the heart and the brain, but you are cutting off bleeding to the abdomen or the pelvis. And so this is sort of like the internal tourniquet. Like I mentioned, it maintains blood supply proximally but cuts it off distally, just like a tourniquet. This is a temporary solution. We do not leave this in there. If you did, you would have ischemia of all of your limbs, and that's just like not ideal or compatible with life. And so this is, again, a very temporary solution. There are a couple of zones of the aorta. 1, 2, and 3 are kind of what you need to know at this point. And so zone 1 is going to be closest to the heart, zone 2 is going to be in the middle, and zone 3 is at the closer to the bifurcation of the aorta in the abdomen. And so you would place, we never ever place the REBOA in zone 2. So we usually only put the balloon in zone 1, which is way up in the chest, and that's more for abdominal bleeding. If you're not concerned for abdominal bleeding, but only pelvic bleeding, you can do it in zone 3. And this is sometimes also used in OB-GYN. So if there's like an OB trauma, or you have like placenta accreta, increta, percreta, some institutions will use a REBOA for those surgeries or have them available. Some reasons why you wouldn't place a REBOA would be like chest trauma. So if somebody has an aortic dissection or they're bleeding a ton from their chest already, what you don't want to do is increase the pressure of the blood flow to that area, because you will just bleed more or dissect the artery more. So that's not ideal and a contraindication for REBOA placement. For blood in the retroperitoneum, like I mentioned, you can use REBOA and occlude zone 3. You can also bind the pelvis. There's also an intervention called pelvic packing, where you can make an incision, can sort of dissect around the peritoneum and shove some packs in the retroperitoneum. This is not often done, I don't think, but it is a technique that is described. You can also call your interventional radiology friends who can embolize vessels for you, and if you can get them down there pretty quick, that can be like an emergent thing that happens, although doesn't happen in the bay. So something to think about for management, but the things that you would do in the moment are bind the pelvis, and you can do pelvic packing in the bay if that's something your center does. Blood in the thighs, like we talked about with those long bones. Returning long bones to anatomic position can help with blood loss. And then gaining proximal and distal control of vessels if you have vascular bleeding can sometimes require cut down of the skin and dissection until you can find them. But clamping those things can be helpful, but you never want to blindly clamp because that can cause more damage than necessary. Really quickly, this is turning into like a 3-part episode because I could talk all day about circulation, but talking about the management of shock, so hemorrhagic shock in this case, let's talk really quickly about IV fluids because this is a hot topic in trauma. IV fluids can absolutely be used as a part of your resuscitation, but you should favor replacing their fluid loss with blood. Why do I say this? So IV fluids first are dilutional, and so when we think about all the things in our blood, the really good things that we need, like coagulation factors, we've got platelets in there, we've got all kinds of things in our blood, and if we are adding tons and tons and tons of fluid for these patients who are losing a ton of volume, not only do they not have a ton of hemoglobin and oxygen carrying capacity, they also now have very dilute coagulation factors, and it becomes really hard for them to stop bleeding. Another thing is patients who have trauma have a ton of endothelial damage, and if you think back to the pathophysiology, endothelial damage and this inflammation and this stress response of their body, they are burning through those coagulation factors that they already have, and they have improper activation of their coagulation pathways due to this extreme tissue damage, and so it becomes really, really important that we do not make patients coagulopathic with IV fluids. So we need to replace these factors in order to keep up with their bleeding and with this like abnormal activation of the coagulation cascades, both breaking down and making clots. So we don't want to dilute their factors, but another thing is excessive IV fluids can also cause acidosis in patients. And so that's not what we want. When we think again back to pathophysiology, acidosis is not helpful for lots of reasons, but another one, just thinking back to coagulation, is those enzymes work in a specific range of pHs, and if we change the pH a little bit too much, we now cannot even activate the coagulation factors that we have left, and it becomes much harder to stop bleeding, even harder. So all of these things contribute to what we call the triad of death in trauma, which is being cold, coagulopathic, and acidotic. So IV fluids can contribute to all three of those, because if we think about it, IV fluids can be very cold, and so infusing a bunch of cold fluid into patients can make them cold, can dilute their factors, making them coagulopathic, and due to the balance of the fluid can make them acidotic, which is the triad of death, and that's something that we want to avoid. So to avoid this, we want to warm all of our fluids if possible. We want to prioritize giving blood products back to these patients. I think typically the limit for IV fluids in like initial resuscitation is like 1 liter, unless you have no resources, but you should not be dumping fluids into these patients. Very, very briefly about replacement of blood products. We can do an entire episode on this because there's a lot to learn. You should get a type and screen as soon as possible so as not to deplete your center of blood products. And what I mean by this is people who come in with traumas, we are not going to wait for their labs to come back to give them blood. So what we're going to do is give them O blood. So we call that uncross-matched trauma blood. And so uncross-matched trauma blood is going to be typically O positive in men and O negative in women of childbearing age. And that is to reduce the risk of the Rh factors becoming a problem in future pregnancies. And so women get O negative, men get O positive because they don't have to worry about that. However, we want to figure out what their blood type is as soon as possible and what blood products are safe to give them so we don't deplete ourselves of these wonderful blood products that we can give to anyone. And this is a quick shout out that if you're able to give blood, you absolutely should, because centers truly do run out of blood, and it becomes very scary when patients come in and need blood. And all we have are these stinking IV fluids. We're just making everybody acidotic. So donate blood, donate life, all the things. Big proponent of those things. We will go over blood transfusion and the data around massive transfusion protocols and the ratios that you should transfuse these products in a different episode. And it seems like we're actually going to have to finish the trauma primary survey in a different episode, but I really wanted to dig into circulation, and there was a ton to cover. I know I talked really fast, and I also know that this is a super broad overview because there is so much to know, but this just gives you a little peekaroni into the life of a trauma surgeon, thinking about all of these things, but thinking about them very, very quickly as they are happening in front of your eyes. So I'm going to call it here because at this current moment, I've been recording for 30 minutes, and this is the longest episode that we've had so far. So I'm going to call it here. We're going to come back next week. We're going to talk about disability and exposure. The exposure part is super fast. So the disability, we will take our sweet time and we will learn a ton about the Glasgow Coma Scale and how to think about the GCS exam. So thank you so much for being here, and I'll talk to you next week. Bye. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon, and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.